each patient on its own and carefully. And bear in mind that all these bicuspid valve patients are usually younger, and we don't know how these valves will behave in the long term. Again, the long-term issue is a concern. And the last indication, the pure aortic valve regurgitation experience is still limited. I think the problem is most patients with AR have also very dilated roots without much calcium to hold the valve down. And it can be done, and there's been several registries now published about this, but I think patients must be very carefully selected. So in 2020, which are the patients that we should consider with severe aortic stenosis for TAVR? I think all inoperable patients with a life expectancy of 1 year, high surgical risk patients, intermediate surgical risk patients, I think they are good. Low risk patients, I think if they are older, not too young, if in the trial it was average of 73 years old, I think it's suitable. There is still no randomized data for severe bicuspid aortic stenosis. The long-term durability of the valve is unknown. And so the conclusion will be that TAVR is indeed suitable for many, many patients, but really not all patients with severe aortic stenosis, especially younger patients that we may see in Asia. And off-label use for pure AR is really anecdotal and limited. Thank you very much.
Wow. Thank you, Paul. That's a great overview of the current evidence. I think we might leave the question time until the end. We have 10 minutes for question time at the end. Is Dr. Fintonsberg here?
I did not see him.
Oh, okay. Did he record the presentation before?
Yes, already. So
oh, okay. So maybe we go ahead with his recording. He's talking on what is the role of surgical AVR in the year 2020. Maybe we go ahead and listen to his recording. We cannot hear. I'm sorry, can you all hear? Because I cannot hear. Okay, maybe we try again.
About the role of surgical valve replacement in the year 2020. We have a lot of material to cover pretty quickly in a limited time, so I want to jump in. I think it's pretty well established at this point that the natural history of unoperated aortic stenosis is dismal, with a very poor to and through survival when compared to those patients that are offered some type of therapy. And I think we need to then start considering more and more what really are the best options, especially in the context of sometimes limited resources. With some of the recent trials, I think it is pretty safe to say that patients that are very high risk or sometimes prohibitive risk may benefit predominantly from a catheter-based approach to their valve, although there is still some inconsistency in that data that is limited by center experience. But the growing debate is really what to do with the intermediate risk and the low risk patients as predicted by their STS risk score, multi-organ system function, and procedure-specific requirements, as well as their evaluated assessment of frailty. But fundamentally, it does beg the question of why would you not want a catheter-based procedure when you consider that open heart surgery is still associated with still pain, discomfort, and complications. And considering all of the marketing that is going involved, TAVR seems to be the way to go. However, I'm not exactly sure, as we will talk about today, that the data supports that this is the best thing for everybody. When we go back to the original SIR-TAVI trial, for which 1,746 patients were enrolled, when specifically looking at all-cause mortality or disabling stroke at 2 years, fundamentally the outcomes between the two procedures were somewhat the same. This served as the basis for some of the non-inferiority conversations that were driving people towards this procedure, thinking that because it was simpler, it was by definition better. And I think it was pretty well established that the quality of life and the recovery for surgery was much more challenging in the first couple of months than catheter-based therapies. However, once the patients got beyond 5 to 6 months and now even extending at 4 to 5 years, the quality of life and the overall performance of these patients is somewhat similar once you go beyond 1 year. And this served as the basis for advocating TAVI in those patients that you had an expected life survival outcome of less than 2 years, and that maybe getting them on their feet sooner was better. However, this does not necessarily apply across the board. In a meta-analysis of over 9,500 patients at 1 year, both intermediate, low, and high risk, one of the things that became clear was that despite all of the morbidity and mortality reviews, that at 1 year, the mortality and rate of stroke really showed no fundamental difference between the two procedures across the board. And furthermore, when you start looking at the mortality outcomes of these patients at 1 year, again, no fundamental difference, particularly in the intermediate risk group, suggesting that both procedures are reasonable. Specifically addressing the question of low-risk patients, this was a review of the randomized controlled data and the propensity score matching studies at the time, almost 3,500 patients looking specifically at the mortality at 2 years. And what they found was there was no fundamental difference between surgical and catheter-based therapies at 2 years with regards to the short-term outcomes and specifically death and stroke. Furthermore, when you start extending this beyond 2 years, the data suggests that there was actually a survival and freedom from major adverse events that tended to favor surgical aortic valve rather than catheter-based therapies. And it is this that we're starting to see where the data converges. And specifically looking at stroke, procedural related, most people don't want open heart surgery because they're afraid of stroke. Nevertheless, both procedures are associated with the same procedural related risks. Furthermore, when taking this to the intermediate risk population, a meta-analysis looking at over 4,000 patients and 14 studies had similar results. And that is at 3 years, the curve started to diverge more and more with a benefit both in terms of survival and freedom from major adverse cerebrovascular events favoring surgery when compared to catheter-based therapies. So in essence, the outcomes are similar at 2 years, but once we start getting beyond 2 years, the benefits of surgery really start to evolve. And then we start looking at the evolution specifically of the low-risk trials, whether it's the Partner 3 trial or some of the recent studies in the New England Journal that came out over the past couple of years. And summarizing them, fundamentally, it suggests there may be benefit-based therapies, particularly in the low-risk patients, but this is only the early data, and it doesn't necessarily translate into all patients. Because in an editorial review of the low-risk trials, one of the things that was brought out were some of the major concerns, specifically highly selective enrollment that may have favored catheter-based therapies. Most studies were intention to treat as opposed to an as-treated analysis, concerns about the randomization protocol and the enrollment of patients needing concomitant procedures, and fundamentally the significance of the endpoints, particularly only at 1 year. Fundamentally, these were not similar patient populations. And to address this, the group out of Israel presented some of their data, registry data, looking at the outcomes at early 1 year and 3 year, and not only in low-risk patients as defined by STS scores of 0.7 to 4, but also specifically very low-risk patients compared to their higher-risk group. And what was quite concerning is that while the procedural mortality was quite low, once you started getting beyond 1 year, the mortality rate in this relatively young, healthy population was somewhat substantial. In fact, in their registry review of over 1,200 patients in both groups combined, the 3-year mortality for the low-risk patients was 20%, and in the very low-risk group, it was over 12.5%, which far exceeds established benchmarks for surgical options in these patients, suggesting that we might be very cautious about low-risk patients. Furthermore, looking specifically again at the French registry longitudinal study, looking at 27 centers with 2-year data and beyond, some of them showing up to 60 months of follow-up and addressing both approximately 800 SAVR patients. What they found was that there was a significant increase in costs with catheter-based therapies beyond with surgery. In addition, they also found at 5 years for those patients that were still alive, a substantial increase in the need for pacemakers, increased risk of strokes, as well as myocardial infarctions. And this is, as I mentioned, once we start getting beyond 2 to 3 year data. In fact, the mortality in this group was almost as high as 45 to 50% at 5 years compared to 35% in the surgical group, suggesting that there really needs to be caution when applying this. The major concern that patients have related to procedure is the risk of stroke. And while some of the existing study data implies that the risk of stroke after TAVI is somewhat similar, if not lower than surgery, this does not necessarily pan out in some of the CMS data. And specifically looking at admissions for stroke, both hemorrhagic and ischemic, in the full spectrum of cardiovascular procedures, we're starting to see that TAVR outside of the trials is associated with a substantial, if not tenfold, increased risk of readmission after the index procedure within 6 months than when compared to other cardiovascular procedures, including surgical aortic valve, cardiac catheterization, CABG, pacemaker, and in fact, the rate of stroke readmissions are even reported to be higher than ventricular assist devices. Obviously, this is a substantial area of concern that needs to be sorted out better. Furthermore, when patients are presented with the options for TAVR, they like the approach of a minimally invasive procedure, and they are told that the rate of permanent pacemaker and paravalvular leaks is much higher. However, the significance of these two events is not exactly completely defined or presented to them at the time. The rate of pacemaker implants and leaks is much higher. We need to really better understand the significance of this. For example, in this one study that was published in the Annals of Thoracic Surgery in 2018, suggested a much worse survival in patients that required pacemaker after aortic valve replacement, either with catheter-based therapies or with surgery, suggesting that the need for a pacemaker independently reduces long-term survival, something that clearly must be presented to the patients when they consider catheter-based therapies, especially when one realizes that the rate of pacemaker implantation has been relatively constant over the years, depending on the techniques. Furthermore, paravalvular leaks, particularly moderate or severe, is not without substantial risk either. This is a review of the PARTNER 2 data that was published in the New England Journal in 2016 that again shows a substantially, if not threefold, worse outcomes in terms of survival for patients that had at least mild or if not moderate to severe paravalvular regurgitation. Again, a complication that is incompletely explained and understood at the time when patients are evaluated for procedures. Furthermore, I need to illustrate a very strong word of caution with the growing trend of TAVR in patients that are relatively young. This is a paper that's still under press and will be coming out shortly in the Annals of Thoracic Surgery, specifically addressing the different techniques in those patients enrolled in the congenital heart surgery and adult cardiac surgery databases over the past couple of years. Specifically looking at over 45,000 patients that are in the age group of essentially 18 to 55 that got different types of valves. And I want to illustrate that the rate of persistent stroke was about 1.5 to 1.6 for either mechanical or bioprosthetic valves, and almost twofold higher in those patients that are undergoing isolated catheter-based valve replacement. Obviously, an area of concern. And just as concerning is the 30-day mortality for those patients undergoing isolated aortic valve replacement, either with surgical therapies or catheter-based therapies. For the predominant number of patients that are getting either a mechanical or bioprosthetic valve, the mortality at 30 days with surgery is on the order of 1.3 to 1.8%. However, again, almost twofold greater for those patients that are undergoing catheter-based therapies. Again, recognizing that as these get expanded to lower risk patients and the desire for minimally invasive procedures, we need to recognize the limitations of the data and that we still need to understand better the role of these therapies. So in conclusion, there are a variety of myths that are associated with catheter-based therapy. Specifically, TAVR patients don't have strokes. We know that that's not true. TAVR patients all get better. That's not necessarily true. TAVR may make money and in fact cost less for the patients, and the French experience clearly shows that to not be true. And there is this misconception that TAVR patients live longer regardless of whether they're low, intermediate, or high risk. This has all led to the assumption that TAVR is better than surgical therapy. However, we still need to recognize that surgical aortic valve replacement is still indicated and appropriate in younger patients, those that are deemed to be lower risk and appropriate intermediate risk patients, particularly those with a life expectancy of greater than 5 years. Now, that's not to say that TAVR doesn't have a role in older patients, higher risk patients, or those with appropriate intermediate risk or life expectancy less than 5 years. Patients with pre-existing or certain high-risk groups, such as previous heart surgery, hostile chest, or frailty, often drive the decision for TAVR, which may be appropriate. However, as we see more and more, there's patients who frankly just don't want surgery, and it is our obligation as members of the heart team to recognize the limitations of the current data and experience, particularly once we get beyond 2 to 3 years, in suggesting that many of these patients would be better served with surgery. Thank you very much, and I appreciate the opportunity to present to this distinguished group, and hopefully we'll have time for questions and answers at the end.
Okay, that's a great presentation from Dr. Fistensberg. I don't think he's online yet, but anyway, we wait after my talk and then see what if he can join us for discussion. So let us finish the third talk. I'm going to, this is a pre-recording. I'm going to talk about the remaining challenges for TAVR in the year 2020. We will have question time after this talk. Can we start my talk, please? Great. Good morning. I'm Michael Lee from Hong Kong. Thank you for your kind invitation and asked me to talk about the remaining challenges for TAVR in 2020. This is my conflict of interest. I'm proctor for the 3 companies, TAVR companies. As you know, our population is aging. And with the increasing number of aging populations, the incidence of degenerative valvular disease, both aortic and mitral valvular disease, are actually on the increase. TAVR has been shown to be one of the best treatment options for this group of severe aortic stenosis patients. So as the patient are aging, the patients the age becomes higher and higher. The number of patients receiving TAVR procedures actually are also on the increase. It has been estimated that in the next 10 years, TAVR growth will increase at least by 3 to 4 folds. This increasing number has also been enabled by the expansion of indications. So to start with, we are treating high-risk patients and then intermediate risk patients. And recently, since last year, we are able to treat those low-risk elderly patients, both with balloon expandable devices or the self-expanding valves. So this will certainly increase dramatically the number of patients receiving these TAVR procedures in the near future. You all heard about how to handle or how to tackle the acute complications of TAVR, but there are some long-term concerns that we have to address before we can actually make these procedures more popular. I will talk this one by one. So first of all, patients receiving PCI after TAVR is not low. Number is not low. At least 3 to 5 to 7% of these patients might require some sort of coronary intervention, be it stable angina or ACS or even STEMI patients. But coronary access might be a problem if there is a TAVI device. Mainly because it depends very much on the valve design, the height of the frame, and as well as the patient anatomy. So in general, when we are doing coronary intervention for a patient has been implanted the balloon expandable S3 device, we can use the standard diagnostic and guiding catheters. But if we are doing coronary intervention for a patient after evolute or the self-expanding valve, sometimes we might need to undersize the guiding catheters by half size, or sometimes we might even need to use some sort of guiding extension catheter or even coronary wires to fish around for the coronary ostium. In general, the shorter frames, balloon expandable devices are actually more easy to get coronary access than the self-expanding higher frame device, especially for the supraannular type of device. But they are all doable. Coronary obstruction is sort of the very dramatic acute complications of TAVI procedure. These are the predictors. So usually when we see low-lying coronaries in a small sinus of Valsalva, then the risk of coronary obstruction might be much higher. Many a time we might put in a coronary stent inside the coronary artery as a protection. So if anything happens, if there's any obstruction, we can pull the stent out and then do a chimney stenting after the TAVI procedure. But recently, the basilica procedure, which is an intentional laceration, especially of the prosthetic valve, or sometimes in a native valve as well, try to make a laceration of the leaflets so that when we put the TAVI device in, it will not be obstructing the coronary ostium. So this is one of the more advanced procedures that we can consider when we are facing with this high risk of coronary obstruction patients. Pacemaker rate has not been decreased any further, even with the newer generation of TAVI devices. You see all the complications are on the decrease of new generation devices except pacemaker implantation. And we know whenever patient needs new pacemaker, this will increase the mortality, future mortality after the TAVI procedure. So our every means is to prevent the implantation of this pacemaker implantation or to prevent heart block development. We know the main reason for patient to develop heart block is mainly because the membranous septum or the right fibrous trigon is very actually close to the non-coronary cups. So when we implant the valve too low, you might actually impinge on this system and then causing heart block. Our aim now is to try to implant high of the TAVI device. These are the possible predictors of conduction disturbances of the TAVI. There are some factors that we cannot control, like pre-existing right bundle branch block or first-degree heart block. But there are other factors that we might be able to control, especially the implant depth. So when we try to implant the valve higher, try to limit the implant depth, then sometimes if the patient may end up requiring less pacemaker. This is our usual way to implant the valve. So this is what we call try to get a coplanar view when we align the three leaflets in a straight line. And by doing this, we can actually implant the valve, try to aim at a high implant with these three dots. But nowadays, it has been advocated that even a more accurate method is to use this cups overlap technique. So what they are suggesting is that they try to overlap the right and left coronary cups. And then by doing so, the lowest point of the non-coronary cups will be exposed. So if we can implant the valve in this angle, so the valve will, the height will be very, very much limited. So if we really try to implant the valve high, this will actually will give the best result of high implant and without missing the annulus. So by doing this, at least in one of the US centers, it has been shown that the pacemaker rate actually decreases quite dramatically by implanting the valve high and not missing the annular plane. So this is something that is newer to our thought that we can employ in the near future when we are doing the TAVI procedure. Reduced leaflet motion or leaflet thrombosis has been implicated in at least 1 in 5 our TAVI patients when we subject them to the 4D CT assessment if we do it after the TAVI procedure. This also happens in surgical AVR, though the frequency is not as high as TAVI procedure. Treatment-wise, we will prescribe patients with anticoagulation, usually warfarin. So although recently some operators may actually advocate the use of NOAD to treat this sort of patients when they have symptoms. But the real scenario of how to prevent this sort of reduced leaflet motion is still under question, because there are still studies going on whether we should add NOAD to our usual antiplatelet therapy. Nowadays, we give only aspirin after TAVI procedure. By added NOAD, might be it will reduce the incidence of this reduced leaflet function or even leaflet thrombosis in the future. But we are waiting eagerly for the Atlantis and the ACTION trial results. Valve degeneration has been implicated when Danny Dever actually presented this finding of dramatically decrease the leaflet function with leaflet degeneration after 6 to 8 years of TAVI procedure in the year 2016. But if you look at the most recent meta-analysis by Capodino, you can see that even after 5 to 8 years, we don't see a lot of severe structural valve dysfunction or prosthetic valve failure, even years after the TAVI procedure, only 1.3% and 3.7% respectively. So there's no signal of early valve degeneration, at least in this meta-analysis. In our hospital, we have been following up with echo in all our patients. So up to 5 years, we don't see any signs of valve degeneration. We are analyzing the up to 10-year result, and I can report to you later on. But at least after 7 years, we have a very reasonable mortality rate of our TAVI patients. And I'm happy to tell you that 3 out of our 4 TAVI patients are still surviving after 7 years of the TAVI procedure. Lastly, bicuspid valve has always been excluded from the clinical trials, no matter it is high risk or low risk trials, mainly because of the heavy calcification associated with bicuspid aortic stenosis, as well as the bulky leaflet associated orthopathy and so on. Sizing is a problem, especially in clinical trials, but for us, we actually follow this recommendation from Didier. So whenever the annulus is smaller than the intercommissure distance size, we actually size according to the annulus. Only when the intercommissure distance is smaller than the annulus distance, then sometimes we might consider downsizing the valve in this bicuspid aortic stenosis patients. And then in the recently presented absolute low risk bicuspid study, you can see that with the use of absolute in this sort of high risk bicuspid AS patients, the primary endpoint at 30 days was only 1.3%. Very, very acceptable results. So out of the 150 patients, only 0.7% mortality and 0.7% disabling stroke out of the 150 patients. And also very reasonable, very comparable other complications as compared to our usual tricuspid patients. And if you look at the valve hemodynamics, well-maintained valves area as well as the mean gradient up to 30 days. And most gratifying to see is this, they don't see any moderate or severe valve regurgitation at 30 days, even for this group of bicuspid AS patients. So I would say for now, bicuspid AS patients, we still can offer a TAVI procedure, but we have to bear in mind some of the more procedure details during the procedure. So nowadays, what we are practicing is a minimalist TAVI procedure. So first of all, heart team, we need to have a multidisciplinary heart team involving the surgeons, anesthesiologists, radiologists, cardiac nurses, all together in a heart team to decide whether the patient is a suitable patient for to go for a TAVI procedure. Usually, we will do this procedure under local anesthesia or conscious sedation, no TEE, no TTE, no central line. We don't put in temporary pacing wire anymore. We do the temporary pacing through the LV stiff guide wire. And then only 114 French sheet over one of the femoral arteries and another 5 French pigtail over the other. Systematically, we will use cerebral protection device through the right radial artery, try to reduce the stroke risk. And then the patient will be ambulated quite early, 4 hours after the procedure, and then discharged within 2 days. This is our usual practice. So with the higher bar in a TAVI procedure in 2020, I would say we are aiming quite high now. We are aiming at 1% inpatient mortality, 2% stroke rate, 3% vascular complications. Usually the procedure can be completed within 1 hour under LA or conscious sedation, and the patient will stay in the hospital for only 2 days. So in this way, more patients will be willing to undergo this sort of minimally invasive transcatheter procedure, and your waiting list will keep growing. Of course, we'll wait for more clinical trials to include more suitable patients. Like in this early TAVI trial, they are looking at whether even asymptomatic severe AS patients should receive early TAVI procedure, or whether moderate AS stenosis, aortic stenosis patients with heart failure actually will also benefit from the TAVI procedure. We will wait for this, the results of these trials before we will expand our indications more. So I would say we have entered a very exciting era for TAVI and also other structural heart interventional procedures. But there are remaining challenges that we have to overcome to make this TAVI procedure more widespread. And these are the remaining challenges that I've just mentioned earlier on. This is our coming meeting, the Chip and Complication Forum in Hong Kong in November. This is a virtual meeting, and you are all welcome to join us on the internet. Just register on the website, and then we will have you for the Chip and complication cases in November. Thank you very much for your attention.
Thank you so much, Michael, for great lecture. Thank you so much.
Yes, great. So we heard the 3 presentations. I don't know whether Dr. Fistenberg is here. Seems he's not here. But anyway, we can discuss among ourselves. Paul, are you still here?
No, maybe is.
Okay, Paul might just be. So you've heard about the good clinical evidence of the TAVI procedure from inoperable, high risk, intermediate risk, and all the way to low risk patients from Paul. And there are some counter proposals of doing more surgical EVR. Actually, surgical EVR results, especially long-term results, might be better from Dr. Fistenberg. And I've also shown you the remaining challenges of the TAVI procedures, both long-term and some of the immediate challenges of this procedure. But I think it comes to the era that patients really want minimally invasive transcatheter procedures, especially the elderly patients, no matter they're high risk or low risk. So we have to offer this sort of treatment. We have to refine our technologies so that we can offer better for the patient and try to contain the possible complications that we will see with this transcatheter procedure. Lynn, you have any comments?
Oh yes, I do agree that now we can expand the indication for TAVI for larger population.
Right.
But the main barrier in our community is that the price, and maybe it's not the problem in Singapore, in Hong Kong, or in the States, but in Vietnam, the price of the surgery is very, very low compared to TAVR. It's just $2,000 or $3,000.
Oh, that's very cheap.
Yes, and our surgeons are quite well. You know that they have performed many cases. Even with a 80-plus-year-old patient, they can still do the surgical replacement. So, although all the patients come to see us first, but normally I recommend them or I refer them to the surgeon to see if the surgeon can do it or not. I think it's the main barrier is the price.
Okay, suppose, I don't know, if with more patients included, enrolled, when the price of the TAVI devices come down, will you be able to offer more of this transcatheter device? Because when you talk to the patient, most of them will not want a major surgery.
Oh, sure, agree.
Cut open the chest. And especially for the elderly, they really stand a very high risk to go for surgical AVR. Sure. So when the price comes down, do you see increase in the number of TAVI patients in your center or in Vietnam?
Excuse me, can you repeat?
Can you see the number of TAVI patients will increase when the price comes down?
Yeah. Yes, I can see the number of cases has increased already. Right. So I think since the beginning of this year, in Vietnam we have up to 20 cases.
Okay.
More. Which is very promising because in the last 7 or 6 years we have the total number of just 90 cases in the whole Vietnam.
Okay.
But since the beginning of 2020, I think nearly 20 cases. In my place, we have done 4 cases, and the next case is hopefully next week. But I think have many candidates for TAVI already, but most of them cannot afford the procedure.
Right.
Yes.
So Paul is not here, but actually I'm going to ask him with the good clinical evidence from this high risk or low risk patients. Most of them are actually not in Asia, not from Asia. So Paul, you are here. You're good. So you see, the evidence you presented, most of them are not from Asia. Do we have good evidence to convince our Asian patients to undergo this procedure? What's your opinion? Sorry, Paul, we cannot hear you.
Can you hear us? You're muted or not? You're muted, Paul.
He's unmuted, but we cannot hear you.
Yes, please unmute.
Okay, maybe something wrong with your computer, Paul. We cannot hear you. So your speaker might not be working well. But anyway, I think this is sort of a generalizable disease because all the populations are actually more or less the same, both for the Caucasians and the Asians. And we actually have our local Asian data, both from the Ocean Registry in Japan, the AP registry, both from Korea. They have sort of collected data from some of the Asian countries. And then there's a Asian Pacific TAVI registry from the APSIC, in which we are actually doing the analysis. I think there will be a paper published soon in Asia Intervention that we have actually shown our AP TAFI registry patients actually doing better or actually more or less the same, or if not better than the other registries in other parts of the world. So I think we have good clinical evidence from this part of the world that actually TAFI procedures can be safely and very practically done in our locality. And we have very good operators in which the complications are actually not higher than any of the European or US countries. I think that's something that will grow because we have 3/4 of the world population in our locality. And I think the TAFI procedures will be increased dramatically in the very near future.
That's great. Michael, may I have a questions for you?
Yes, sure, please.
So based on your presentation, do we have any consensus now about antithrombotic therapy for patients before and after TAFI?
For now, I would say there clinical evidence to show that single antiplatelet agent might be the same as dual antiplatelet agents after the TAFI procedure for now, but we don't know the exact incidence of reduced motion or even valve thrombosis after the procedure. So we will wait for the proper clinical trials, the Atlantis, the action trials, to tell us more whether we should actually put some of these more high-risk patients under the newer anticoagulant, the NOACs, to prevent this sort of valve thrombosis. But for now, at least in our hospital, we are only giving single agent, aspirin only, to our post-TAFI patients. And they don't come back with any problem so far for the past few years.
That's very good.
I would say aspirin for now, and we wait for whether we should add NOAC in the future.
Yes. But aspirin, you mean that for patient without AF, but if patient has AF.
Of course, if patient is with other indications, we would just give NOAC.
Sure.
And no aspirin, just NOAC.
Okay. Thank you so much.
Thank you. So it seems Paul is not able to join us at this moment.
You can hear me now?
Oh, yeah.
Yeah, sure.
I don't know what happened.
Okay, Paul.
I'll come back. Oh, Dr. Fristenberg is here already.
Yeah. Michael is here. Good to have you. Paul, would you like to say something more about our Asian evidence, Asian population?
No, I heard you. I think the randomized data is what it is, and I think the results that we see in Asia it's equivalent. I think it applies, but just that there are some things that we have to be careful about. The randomized data is promising, but it doesn't tell us everything right now yet. So we just have to be careful and follow the evidence that we get as we go along.
Okay, good to know. Sorry, Dr. Fistenberg, we don't have you for the past few lectures, but now we have you. Can I just ask you, in your presentation, you stress very much on the better clinical outcome, especially the long-term outcomes with surgical AVR, both in terms of mortality and stroke. So in your opinion, would you, what sort of patients would you actually subject them to the TAFI procedures instead of surgical AVR? What do you think of the bicuspid patients? You didn't specifically mention about the bicuspid patients. Can you unmute yourself, Dr. Fistenberg?
There you go.
Yeah, we can hear you. Thank you.
Thank you. So I think a couple of things. One is with the bicuspid valves, A lot of it depends on the actual anatomy of the valve. But one of the problems that we've seen is that sometimes you really don't get a very good seal with the TAVR valves, and that sets patients up for at least some degree of paravalvular leak. And when you consider that this is a population that is relatively otherwise young, I think we're starting to see more and more that paravalvular leaks are in themselves an independent marker of a poor outcome. And so I think that in a younger population with bicuspid valve, even though it is feasible and the short-term results are reasonable, I think it's very difficult to really get a good seal. And also because of the nature of, from a surgical standpoint, the valves I think are much heavily calcified in that area. And so it doesn't really allow for good expansion. And I've seen quite a few bicuspid valves that leave the hybrid room or are back a couple months later with very high gradients. And, gradients, 20, as high as, 20 millimeters of mercury mean gradient, which really, again, when you're thinking about a younger population, is an issue. Yeah.
Yes, great. And the other question is, we know the ESC have updated their guidelines, and I bet that the US is going to update their guideline too, because they put in maybe at the very end, patient preference as one of the indicators to guide the heart team whether to subject the patient to surgical AVR or a TAVR procedure. So in your opinion, how important should we consider patient preference?
It's most patients don't want surgery, and I think that's somewhat reasonable. In the United States, I think it's more of an issue than in other parts of the world where patients are more likely to listen to their to their doctors. I think the problem is that we're seeing a lot of patients already coming in and saying, I want TAVR, I don't want surgery, I don't want, I don't want it. And they have a hard time accepting that that's not really a good answer for them. And one of the things that I think we're going to start seeing is what we call buyer's remorse. I'm not sure if that's a term that you're familiar with in your country, but it's when you buy something and you can no longer return it and you're not very happy with your purchase. And I think we're going to start seeing over the years a lot of younger patients that have gotten TAVRs that are really not very happy with their choice. Whether it's several years down the road when they need a repeat intervention, when there's concerns of coronary obstruction, and I think we're starting to recognize that the decisions that we're making now really impact these patients long term, and it's going to probably take a few years to settle that out. But I think part of the problem is also the way that the systems are set up. Cardiologists, and I know this is a cardiology meeting, are very aggressive in pushing and wanting to do TAVR, but they also have to recognize that sometimes that's not the best option. So.
Yes, I agree. Actually, we work very closely with our surgical colleagues. We have a heart team, so we decide together which patients go for TAVR, which patients go for surgical AVR. And we always have a compromise or consensus on what kind of stand to take to refer these patients. And
right. No. And I think, people try to do that, but, so for example, today I saw a patient, he was otherwise a low risk patient. And as part of his workup, he gets a catheterization, and the cardiologist, knowing that this is part of a workup for TAVR, sees that he's got a proximal LAD lesion and puts a drug-eluting stent in.
It was stented.
And you're like, okay, and there's no data to support that, and it really creates a problem, and all of these issues add up. One of the things that, I was actually talking with somebody today I don't remember what trial it was, but I can try to pull it up while we're talking here. But they just released the outcomes of one of the cerebral protection device trials, and the device itself was associated with a much higher rate of neurologic events than what was seen in the patients that were randomized to no device. Okay, that's understandable. But in both populations, and I think this was an intermediate risk population, the stroke rates that were being reported in this study were actually much higher than what we saw in, let's say, the CERT-TAVI or the original Partner 2 trials. And so I think we have to be very careful as we start filtering through all this data to recognize that in a very highly selected patient population for some of these very high-profile trials, that doesn't necessarily correlate to what we're seeing in real life. And I think that that's something that, when a surgical patient has a stroke after surgery, everybody knows about it because it's in the hospital. But, when a TAVR patient has a stroke, they're already home, and then they get admitted to another hospital or they get admitted to another service. And, as I, in my presentation where I showed one of the data that shows that there's a lot of these patients that are having neurologic events that we may not necessarily know about. And I think we have to be honest with this. And I've seen some, not necessarily in our program, but in talking to colleagues around, the country, I think that the outcomes in the original Partner 3 trial were very good, and it's going to be very difficult for them to be matched in real life. And I think that's going to set up for a lot of problems. I think when this first started sorting out early on, people were saying, if you have surgery and then there's a bad outcome, they're going to say, well, why didn't you have TAVR? I think that pendulum is going to switch in the other direction, where if people start, when you start having bad complications, low risk patients, that's really going to start opening people's eyes to these kinds of things.
Right. Okay, thanks a lot. I think our time is up. Thank you very much, Paul.
And I apologize for being late. Yeah, hopefully my presentation came through.
Oh, your presentation was excellent. Great.
Okay, thank you.
And we asked you all we want to ask at the end. Thank you very much, Dr.
All right. Well, I apologize. The time differences are a little bit, I thought it was coming up shortly, so I'm sorry.
No problem. Okay, so if you let me summarize, I would say we have a very good session on the aortic valve disease this morning. We have Paul to show us very good clinical evidence from the inoperable to intermediate risk and then to the low risk group of patients going for TAVR procedures. And we discussed whether most of Asian patients should receive this treatment as well. And then Dr. Fistenberg actually showed us his perspective of the surgical AVR. We know most of this, especially the low-risk younger patients, should go for surgical AVR instead of the TAVR procedure, mainly because of the long-term outcomes have not been matched with the surgical AVR patients with our TAVR procedure, especially for the low-risk younger patients. And lastly, I've shown you the remaining remaining challenges of TAVR in the year 2020, both in terms of coronary access, pacemaker rate, valve thrombosis, valve degeneration, and then touch on some of the bicuspid aortic valve issues. So I hope you've enjoyed the session, and we hope the procedure, the TAVR procedure, as well as surgical AVR, actually will be on the increase as we recognize the problem as more and more patients are coming to our treatment in the very near future, not only in Asia, but across the world. So thank you very much for attending this session, and we hope you enjoy the rest of the session, the rest of the meeting. Thank you. Bye-bye.
Thank you so much.
Thank you, Michael.
Thank you.
Thank you.
Bye-bye.
Have a good morning.
Okay.
You too. Have a good morning. Or you have a good day. Good night.
Thank you. Yes.
Thank you.
Yes. Bye-bye. Bây giờ mình nghe em cái này phải không? Thôi nhá.